About Fertility by Nova IVF Centers. Today, our speaker for the day is Dr. Sulbha Arora. Dr. Sulbha Arora is a gynecologist and IVF specialist with over 22 years of experience as a doctor and over 16 years as an IVF specialist. She has been listed in the top 9 IVF specialists of Mumbai 2020 in a peer survey conducted by the Digimedia Inc. and India Today. She is a managing committee member of the Indian Society of Assisted Reproduction for 2021 and a Mumbai Ops and Gynec Society of 2009 and 10. She is a recipient of several awards, including the MOGS, Dr. Shanti Bai Gulabchan Traveling Fellowship from Kaim Sheba Medical Center, Israel. Dr. Sulbha has been a key feature in establishing and operating several IVF centers in Mumbai over past 2 decades. As her fertility struggles are in the subject close to her heart, she is actively involved in a social raise awareness. She has a rich experience in imparting education in IVF, has authored many books and chapters, and has trained many gynacs from India and abroad in the field of reproductive medicine. Today, Doctor will be speaking about the myths and facts about IVF. I now request Dr. Sulbha to kindly take over the session further.
Thank you, Shreya, for the kind introduction. Welcome, everyone. Wishing you a very good afternoon and welcome to today's webinar. We have a very interesting topic that we are going to be discussing you today and a session that gives you a chance to have all your doubts about IVF cleared, to find out what are the facts and what things that you might have heard are just plain myths. So before we begin with busting some of the myths, let us understand in brief what is IVF. IVF, or in vitro fertilization, involves taking the eggs from a woman's ovaries, fertilizing them with the husband's sperms, and then transferring the resulting embryo back into the uterus. So the fertilization that should have taken place inside the body is now taking place outside in the lab. But once the embryo is transferred back into the uterus, nature takes over and the resulting pregnancy is like any pregnancy that was conceived naturally. All we are doing with IVF is giving nature a little push by overcoming the barriers that might have been preventing the pregnancy. So unfortunately, though, there are a lot of myths that are related to this topic, myths that might arise from a lack of awareness, a lack of reliable information, and there is a lot of hearsay. You might have heard people talk about IVF, though not everybody's experience may be the same as what you will undergo. So one of the main things is before you embark on your journey, you must clear these misconceptions, and which helps to remove the social stigma surrounding these procedures. And not just the social stigma, as they say, the fear of the unknown is always worse than the fear of the known. So once you are aware, once you have understood the facts, you are more comfortable when you are undergoing the IVF process. Your fears have been put to rest and the process becomes much more comfortable for you. So let's start with some of the myths that we have also heard, because these are questions that patients do ask us, and these are queries that you might have in your mind as well. For example, a lot of people wonder whether the IVF is very difficult, it's complicated, it's going to be a painful procedure. And another question we get is that I'm a working woman. I've heard that I'll have to take bed rest during the treatment or after the embryo transfer. The reality is that all these things are complete myths. It is not a complicated or a painful procedure. It is a simple and straightforward procedure. It is an outpatient-based procedure. Yes, from the first or the second day of the cycle, for about 10 or 11 days, you will be given a course of injections once daily. And I know that sounds scary, but it is just one small prick. These are normal injections. The needle is not thick. The injections are not oily or heavy. Most women go through this part of the process very comfortably. During these 10 or 11 days, you will be called to the clinic 3 or 4 times to get your follicular monitoring done for us to see how well you're responding and adjust the doses. In 10 or 11 days, once your follicles are ready, we will schedule your egg pickup procedure. Now, the egg pickup is a simple procedure. It is not a surgery. It does not involve any incisions, any stitches, nothing. The eggs are collected through your vagina. Yes, because we need a needle to bring the eggs out and we absolutely don't want you to feel any pain. This part is done under complete general anesthesia. We call it short general anesthesia because the process lasts only for 5 to 10 minutes. So you'll be completely sleeping. You will not feel a thing. As soon as the process is over, you will wake up because you'll be a bit drowsy. You'll rest here in the recovery room for a couple of hours. And once you're feeling fresh, you will head back home. During the process, you can continue to work. After the embryo transfer, also, you can continue to work. Now, you have to understand that bed rest is meant for someone who is sick, who is recovering from an illness. Are you sick? No. All we are trying to do is get you pregnant. So you absolutely don't need any bed rest. And this has been scientifically shown that bed rest does not increase your chances of pregnancy. In fact, it is putting you in an absolutely artificial environment, artificial condition, which your body is not meant for. Your body is meant to be active, to function normally. Reproduction is a normal part of your physiology, and it will work best when you keep your body as close to normal as you possibly can. When a woman conceives naturally, she only finds out she's pregnant after her missed period. They don't go about after the 13th, 14th day of a natural cycle lying down and taking bed rest in order to try and get pregnant. So bed rest required after an embryo transfer is also a complete myth. Now let's come to the next myth that you might have heard of. Some people ask us, oh, an IVF means you're going to take donated eggs. Donor sperms. The fact is that all IVF cycles are not done using donor eggs or donor sperms. In fact, in most cases, IVF is done using the wife's own eggs and the man's own sperms. Even in cases where the ovarian reserve is extremely diminished and there are very few eggs left, a self cycle using your own eggs is still possible. And the same with a man who has got very poor semen parameters can still father a child using ICSI. In some circumstances, you may need to use donated eggs, for example, a premature ovarian failure, a menopause, failed attempts with your own eggs, and similarly for the man where there is absolutely no sperms in the ejaculate and no sperms retrieved even after a surgical sperm retrieval. In such cases, the options will be discussed with you, your consent will be taken, and only then donor gametes will be used. So that is not the norm. That is only for cases where it is really needed. Another question that we get asked is that an IVF pregnancy is something artificial. The babies born have got higher chances of abnormalities because they were not conceived naturally. Again, this is not the fact. This is not the truth. Studies have shown that the incidence of miscarriage and the incidence of having a successful healthy live birth is more or less the same in a naturally conceived pregnancy and in an IVF. So this is also a myth that an IVF increases your chances of having an abnormal baby. No, as I mentioned before, the resulting pregnancy is like any normal pregnancy. It is like any natural pregnancy. So any risks or complications that may occur in any natural pregnancy may also occur in an IVF pregnancy with the same chances or the same likelihood. Similarly, at the time of delivery, some people ask us, will I necessarily need a cesarean because I had an IVF? No, that is also not true. Just like in any naturally conceived pregnancy, at the time of delivery, depending on the circumstances, you may have a normal vaginal delivery, or due to some reason, you may need a cesarean. It is the same in women who have conceived with IVF as well. You can have a normal delivery or you may need a cesarean depending on the circumstances at the time of delivery. The next thing that people ask us is if the medicines that we use, the injections that we give, they are hormonal, they will have some dangerous side effects, some long-term side effects. Are they harmful? Will we gain weight? The stimulation protocols that we use are very safe and patient-friendly stimulation protocols. the injections that we give you for 10 or 11 days to grow multiple eggs, they contain the same natural hormone that our body uses to produce eggs. So the injections used are not dangerous chemicals, they are not harmful. In fact, they don't have any long-lasting side effects. The effect of one injection lasts only for 24 hours. That is why the next day we have to give it to you again. So the effect lasts for a short while only. Earlier, about 10 or 15 years back, the protocols that were used, you can see in the box on the left side, the injections used to start from the previous cycle 20th day itself. So in all, you were taking around 20 days of injections, and the doses of gonadotropins used in the past were also much higher. But now, mostly we follow the protocol you see in the box on the right side. So the injections only start from the second day of the period and they last only for 10 or 11 days. Not just that, we use much lower doses of stimulation of gonadotropins than that were used in the past. So they don't have any long-term effects. These are not the injections that will cause you weight gain. Progesterone can cause bloating in some women. Progesterone is used after the embryo transfer. The bloating is water retention. It is not fat gain. So it is transient. It goes away. It's not something that is going to stick with you. Now, another question that we get asked very often is that IVF always results in twins or triplets. Yes, for sure, you would have seen a lot of increase in twins and sometimes even triplet pregnancies around you in the media, with the celebrities or in your own friends or family circle. Now, first of all, it does not always result in a multiple pregnancy. It all depends on how many embryos you transfer. So if you see the white box in the center, this shows you the journey of an egg from day 1 when it is fertilized up to through day 2, day 3, day 4, up to day 5 when it reaches what we call a blastocyst stage. Now, human embryos have been designed in such a way by biology that not every egg is going to become a blastocyst. There are chromosomal abnormalities in our eggs, in the embryos, that will prevent them from growing all the way up to the day 5 stage. So when you see on day 0 or day 1, you have a certain number of eggs, but then as they progress further, the number that is still growing continues to decline till it reaches the day 5 or day 6 stage, which is called the blastocyst, which you see in the picture on the left. Sometimes all the eggs may become blastocysts, but sometimes not all the eggs will reach there. So when you conduct a genetic test on all the embryos that stopped growing before they reached the day 5 stage, you will find out that most of them were abnormal. That's why they stopped growing. Now, if the embryo transfer is done at an earlier stage, that is the day 2 or the day 3 stage, which you see in the middle image, because most of the embryos will reach that stage, and because we don't know which one will click or which two will click, when embryo transfers are done at that stage, clinics do tend to transfer multiple embryos, maybe 3, maybe 4, with the hope that 1 or 2 of them will click. But what if all of them click? That is when you end up with triplets or quadruplets. That is why it is always preferable to wait up to blastocyst stage, because by then the embryos that are not destined to grow further would have stopped growing, and you have a better selection of which 1 or 2 embryos can be transferred, minimizing your risk of a multiple pregnancy. Now, in spite of, at NOVA, we never transfer more than 2 embryos, for example, and we usually do it at blastocyst stage. Now, in spite of transferring 2 embryos, not every woman will end up with a twin pregnancy because they don't necessarily both implant. So if you transfer 2 embryos in, say, 10 women, out of that, 3 or 4 may end up with a twin pregnancy, but the rest will still have a single pregnancy. And now, because people are becoming more aware, and for us as clinicians, we anyway know that a single baby is healthier. Twins may have a slightly higher risk of complications, including premature delivery. We prefer to transfer 1 healthy single embryo at the blastocyst stage. So for couples who are okay with that, we are more than happy to transfer 1 embryo. Any excess embryos that have been formed can be frozen and kept for you, because just in case you require another attempt, or supposing the first attempt has clicked, but 2 or 3 years later you are planning a second child and you still have frozen embryos from the first attempt, those can still be used for another embryo transfer. Of course, all this depends on having a good quality lab with good equipment, good trained embryologists, and if all that is in place, then blastocyst transfer, reducing the number of embryos you are transferring, is the ideal way forward. Is an IVF always successful in the very first attempt? Some people think it's a guarantee. No, that isn't true either. When you're trying naturally, any couple would have a 5 to 10% chance of conceiving each month, given all their reports are normal. When we try simpler treatment methods like IUI, this chance increases to about 15 to 20% per month. And IVF can increase this chance even further to up to a 60 to 70% chance per month, which means in a given month, if 10 couples try IVF, 6 or 7 may conceive in the first attempt, but 3 or 4 may need to try again. Now, that is not something to lose hope about. This is how the science works. As I was explaining, we are overcoming barriers. We are giving nature a little push as compared to trying naturally or with IUI, where it's dependent on healthy fallopian tubes picking up your egg, bringing it into the uterus, the sperms finding the egg and fertilizing it. Here we are doing all this aspect is done in the lab. So the eggs are taken out. It doesn't matter if the fallopian tubes are healthy or not. It doesn't matter if the egg and sperm interaction is failing. We are making the embryo and putting it back into the uterus. So now nature's job is much easier. It's just that one step of implantation and further growth of the baby that's still left. However, that part may not always click. So still, we cannot say that IVF has a 100% guarantee, though yes, the chances of conceiving with IVF are much higher than with the simpler treatment options. Another thing that people believe is that IVF to hai na, we can always try IVF later if nothing has worked out now. It will always work. But that's not true. The single most important determinant of a couple's fertility is the age of the female partner. Now, you must have heard of the term biological clock and the fact that it ticks and the fact that it gets more difficult to conceive as you grow older. Why does that happen? Now, as we grow older, as age progresses, the uterus remains a strong organ. Mostly the uterus doesn't get affected by age. What gets affected is our ovarian reserve. So women are born with a fixed number of eggs, and that is the quota we have for the rest of our life. We are never going to make new eggs. To give you a perspective, a woman is born with around 20 lakh eggs. By the time she gets her first period, this is already reduced to 4 lakhs. And this is a decline that continues throughout life. Since this is an aging process, it affects everyone's body differently. So to give you an example, completely unrelated to this, it's like white hair. You might have seen some girls have white hair in the 20s, but some don't have white hair even till they are 38 or 39 or even 40. Because it's an aging process that is going to affect everyone's body differently. Now, similarly here, the aging process affects everyone's ovaries differently. So yes, the ovarian reserve does decline with time, and as the ovarian reserve goes down, the chances of conceiving do reduce. But this point is not necessarily dependent on age. So you can't assume that, I'm only 32, I have a great reserve left. Or, my cousin is 38, she still conceived naturally. That might be possible. But then everybody reaches the point of severely diminished ovarian reserve at a different time in their lives. So you need to get your ovarian reserve evaluated. And based on that, we will be able to tell you exactly what chances you have with IVF. And not just that, as a woman's age increases, the percentage of abnormal eggs increases as well. Abnormal in the sense there are chromosomal abnormalities that increase as we grow older. So in our 20s, the best eggs are given out. When we step into our 30s, the decline in ovarian reserve, it goes hand in hand with quantity as well as quality. And as we grow older, it's likely that a majority of the eggs we are producing have got a chromosomal problem. And because of that, though we may conceive, we need to keep in mind that there is also a higher risk of miscarriage at older ages. Because if the chromosomes are not normal, it may either lead to a negative pregnancy test, or it may lead to a miscarriage, or it may lead to a baby with chromosomal anomalies. So as you can see in this table, the risk of a spontaneous miscarriage in the 20s is hardly 11 or 12%. But after 35, it becomes 25%, and after 40, it becomes 51%, because it's going to keep increasing as the age increases. And not just that, when I said that, the best eggs are produced at younger ages. So in a woman in her 20s, supposing she has 10 oocytes, out of that, it's likely that one or two may be abnormal, but the remaining will be healthy and normal oocytes. As we come to 30s, this ratio becomes half-half. And as we cross over beyond 37 or 38, the large majority of our eggs might have chromosomal abnormalities also. And this is where the PGT, or the pre-implantation genetic testing, helps you. So if you are trying for a pregnancy with your own eggs, but your age is already advanced, it's more than 35, 36, you may consider wanting to do a genetic test of the embryo before putting it back into your uterus. Under the microscope, we can see the structure, we can see the morphology. Some abnormalities we can make out under the microscope, but not necessarily all. If you have done the genetic test of the embryo, found out that this embryo has got normal chromosomes, and then transferred it into your uterus, your chances of it clicking and giving rise to a successful pregnancy and a healthy live-born baby are much higher. So as you see on this slide, this is called the paradox of life, unfortunately. What happens is, when we are younger, in our 20s or in our 30s, to get one normal blastocyst, all we need is 6 oocytes, because they are going to be of better quality. As we grow older, 39, 40 years, to get one normal blastocyst, we need around 11 eggs to start with. And after the age of 40, to get one normal blastocyst, we need almost 18 eggs. So as we grow older, the number of eggs we are producing is getting lower, and the number of eggs required for a successful pregnancy is getting higher. So the success of IVF also depends on what age you are getting the IVF done at. Now, right after the embryo transfer, some women are skeptical to get up. We've done the embryo transfer. Her bladder is so full because it's done under a full bladder. We tell her, you can get up, you can go to the washroom, but they are so worried that if we get up, the embryos will fall out. The embryos cannot fall out. They are seated deep inside your uterus. So you can get up immediately after the embryo transfer. You can go to the washroom. You can continue all your normal activities. As you can see here in the two images, the embryos are put deep inside your uterus, from where they are not going to come out. What makes us feel that, we are not able to do this, or whether this is painful, is only the fears in our own mind. The human body has been designed with a lot more sense than that. It's not so fragile that embryos are just going to come toppling out. As you can see in the image on the right side, this is how the ultrasound is actually done. It is done with a full bladder, with an abdominal ultrasound. This is how the image looks. So we can see exactly where the embryos are going. Those are the embryos. This is the embryo transfer catheter. We can see where it's going, where we have placed the embryos. So once it's done, you can get up, you can safely go to the washroom. Even if you jump, the embryos are not going to fall out. This is what I tell all my patients, though I don't recommend you get up and start jumping. But yes, don't be afraid, the embryos will not come out. Sometimes an IVF may not work. As I explained earlier, it doesn't always work in the first attempt. And then I know it's heartbreaking, it's disappointing. We had all our hopes all high, and then you tend to think it's finished now, it's all over. But that's not true either. As I mentioned, it has a 60 to 70% chance overall of working in one attempt. It may be less or more depending on your reports, your age factor, and other parameters. But if you have tried one IVF and it hasn't worked, you can always try an IVF again. For a lot of couples, it works in the second attempt. For some, it even works in the third attempt. If 3 embryo transfers have not led to a pregnancy, then we call it a recurrent implantation failure, and we may ask for some advanced tests to be done. But if the first one hasn't worked, in most cases, you need nothing additional. Yes, by looking at the progress of your embryos, we can find out and tell you if we thought that there was a poor egg quality or a poor sperm quality, and accordingly what changes can be made for your next cycle. but it's definitely not the end of the road. In fact, if all your reports are normal and you are undergoing an IVF because simpler treatment methods that you tried in the past did not work, after your first IVF, there are even couples who still conceived naturally. So a failed IVF in the first attempt is not the end. It may be a comma, it's not a full stop. We can definitely try again. Now, sometimes embryos need to be frozen, but couples are worried that if we freeze it, will it harm the embryos? And shouldn't a fresh embryo transfer be better? Shouldn't it be preferred? Now, what has happened is over the years, we have developed very efficient freezing techniques. In the past, we used to use a technique called slow freezing. Now, slow freezing used to cause a lot of ice crystal formation within the embryo, due to which, once they were frozen, almost 40% of embryos did not survive after thawing. So we used to recommend it only for couples that had too many leftover embryos. Rather than discarding, you can freeze them. But the newer vitrification techniques are so efficient that we get almost 100% embryo survival rate. In very rare cases, it happens that maybe after thawing, the embryo didn't do too well. So now the chances of success with a frozen embryo transfer are as good as they are with a fresh embryo transfer. We don't recommend a frozen embryo transfer for everyone, mandatory, like, you have to freeze and then transfer later. It's not like that. But then there are certain circumstances where a frozen embryo transfer, in fact, has a higher chance of giving you a pregnancy than a fresh embryo transfer, or it may be safer for you. For example, you've undergone the stimulation and you've made a lot of eggs, more than 20 eggs. That is called hyperstimulation. When you are hyperstimulated, the estrogen levels in your body are quite high. In those circumstances, if we do a fresh embryo transfer and make you pregnant, the rising hormone levels in your body can put your health at risk. So in those cases, we recommend freezing the embryos, letting your hormones cool down, and then you can do an embryo transfer in the next attempt. A frozen embryo transfer is a much simpler process. You don't even need any injections. You just have to take tablets. Your embryo is already ready. You transfer it. Then there are certain other conditions where a frozen embryo transfer may be required. Maybe if your progesterone level has become too high before the trigger injection, the embryos won't implant. If you transfer them in the same month, then they have to be frozen and transferred later. If you are doing a PGT or a genetic test of your embryos, again, the embryo has to be frozen because it takes a while for the report to come, and then they are transferred in the next cycle. So the complication rate is minimal. Not just that, people ask us, how long can the embryos be frozen? The duration of freezing does not impact their quality. So as I was explaining earlier, that there have even been times when people have frozen the extra embryos because just supposing the first embryo transfer is negative, the second time they don't have to go through the whole process again, the stimulation again. They can just take the frozen embryos and transfer them. And not just that, if the first embryo transfer has clicked and they've managed to give birth to a healthy baby, there have even been couples who've come back 2 or 3 years later and taken the same frozen embryos from that crop and had their second child as well. So a frozen embryo transfer does have its benefits, and also it gives you a lot of freedom in terms of planning your family. Now, say you got married and you may be, in your 30s, 34 or 35, you're running out of time, but you don't really want to plan a child right now. You may be having other pressures. There is careers to be thought about, education to be thought about. In such cases, you can always undergo a cycle, freeze your embryos, and then it takes that stress off your head. So then when you come to a point where now everything else is settled and you're ready to have a baby, instead of trying at an older age to do an IVF cycle, you can use embryos that you had frozen at a younger age, because the chances of success will be much better if the embryos were formed when you were younger. Similarly, for women who are still single, we freeze unfertilized eggs. For married couples, they can freeze fertilized embryos. So it gives you a lot of freedom as well. Another myth is that, like I said, we stimulate your ovaries, we take out multiple eggs. So will that empty your eggs from your ovaries? Will you reach menopause faster? Because I would have made one egg, but you took out so many. So now what happens? So that is also not true. The way our body functions is that we have a reserve, which is kind of, you can say, like a swimming pool full of eggs that we were born with. Each month, your body is going to take out one bucket of water, use one glass, and throw away the rest of the bucket. So here we are only trying to ensure that that bucket is not thrown away, that is utilized as well. It would have anyway been thrown away. So similarly, you have a pool of eggs that you were born with. Each month, your body is going to select a few eggs, out of which one will grow in a natural cycle, and the rest of the selected eggs will be thrown away. They will die out. So when we stimulate you, all we are doing is ensuring those selected eggs are all used. They are not wasted. They are not thrown away. We can't pull out more eggs from the pool inside. So that will not be touched, and that therefore that will not deplete faster. It will still deplete at the same rate at which it would have depleted were you not doing an IVF. So those were some of the myths and the facts behind them. And that brings us to the end of my presentation. And the session is now open for any questions that you may have. You can go ahead and ask them.
Hi, ma'am. Thank you for the wonderful session. It was really very, very interesting. And I hope lots of myths and facts of the patients who are listening to us have cleared up, as these are very, very common questions, but many people don't know what are the correct answers for it. So I have a few questions coming up, ma'am. I will take it one by one and you can explain to our patient. So the first question is, I am a 41-year-old woman. I got married 3 years back now, and she's not able to get pregnant since then. And her periods are normal. So she's asking, will surrogacy help me? As I've heard that conceiving after 40 years of age is a bit difficult.
Yes, so this is also a common misconception that people have, that as they grow older, they may need a surrogate to carry the baby. Now, a surrogate is required for women who are physically incapable of carrying a child. For example, someone might have had to undergo a hysterectomy, even at a younger age, where the uterus had to be removed, or the uterus may be scarred, or the woman may be having some kind of a medical condition, such as a heart disease, that would put her life at risk if she were to try and carry the pregnancy. Those are the cases where a surrogacy is required. As I mentioned during my talk, that as we grow older, the uterus does not get affected by age. Your capacity to carry the baby remains strong. So as you get older, a surrogate is not what you need. If your uterus is fine, what you may need though is an egg donor. Even then, though you may be 40 or 41, it's not necessary that everybody will need an egg donor. We will first assess your own ovarian reserve. There are two ways to do that. One is by a blood test called the serum AMH. This reduces with age. If it goes down to below 2.5, below 2, we know that we are coming down to the diminishing ovarian reserve category. And if it is less than 0.5, the chances of conceiving with your own eggs would still be there, but considerably lower. Similarly, there is another test which we do on ultrasound, which is in fact even more reliable. It's called the antral follicle count. So we count on the surface of the ovaries how many follicles we can see. In younger women with very good ovarian reserve, we normally see 12 or more than 12 follicles in all. Once this starts to reduce, we know that now we've started to run out of time. If we don't even see 4 follicles in all, that means 1 or 2 in each ovary. These are the women where we recommend that a donor egg IVF would definitely help you. That being said, it is a very personal choice. We will assess your reserve. We will tell you what your options are. What are your chances in your case with your own eggs? What are the chances with the donor eggs? And then you can tell us what are you comfortable with. There may be one couple who feels that even if the chances with my own eggs are 10 or 20%, I would still like to give it a shot. There may be another couple who feels when the chances are that low, we'd rather just go with the process that is going to give us a better likelihood. No decision is wrong. It depends on what are you comfortable with. You need to make this decision after understanding your chances and make an informed choice so that you know what to expect out of the cycle. So yes, at an age of 40 or 41, If your uterus is normal, you may need a donor egg, but definitely not a surrogate. Shreya, you're on mute. I can't hear you. Shreya, you'll have to unmute your mic. I can hear you now.
It's fine. Yeah, I think this question was a really nice one. It clears the concept of, surrogacy and IVF, though they go hand in hand, but they're actually not the same. Okay,
Yeah.
so the next question is, I think this patient has recently undergone an embryo transfer, and she asks, what food should be avoided after the embryo transfer? I have heard that fruits like pineapple and papaya can cause miscarriages. So is it true?
Now, this is also actually very, very, very common misconception. And even if you try to read online, you'll find a lot of sites that say that, yeah, these fruits should be avoided. Now, firstly, they can't cause miscarriage because they don't actually cause uterine contractions if eaten in the quantities in which we normally would eat them as a fruit or as a salad. Raw papaya can cause uterine contractions, not a ripe papaya. But even for a raw papaya to cause a miscarriage, you would need to eat very large quantities of it. And nobody really has, a half a kilo or 1 kilo of papaya in one go. That much can, of course, make a difference. But if you are eating these fruits in moderation, they are not going to harm you. Please go ahead. They are very nutritious. The few restrictions that we do tell after an embryo transfer is caffeine to be limited to 2 or 3 cups a day, tea or coffee, not more than that. And obviously, once the embryo transfer is done, no smoking and no drinking. Of course, if you've been planning a pregnancy, then ideally you should quit smoking even earlier, even before you've started, because a lot of people, are aware that smoking can cause cancer, but a lot of people are not aware that smoking can cause infertility. So in women, it causes a much faster depletion of the ovarian reserve. It gives rise to poor quality eggs. Similarly, in men as well, it gives rise to poor quality of all the seminal parameters. That means the count, the motility, the morphology, the DNA fragmentation is high, so their capacity to fertilize an egg, give rise to a healthy embryo is low. Smoking is something that should have been quit beforehand, but if it hasn't, then after the embryo transfer, definitely. And yes, as I mentioned, avoid the alcohol and cut down on caffeine. Those are the restrictions you require.
Okay, these are very simple, what you say, restrictions that can be manageable, I think,
Yes,
by
they can be
everyone.
managed. Yeah.
Yeah.
Also,
Okay,
another
and
thing that I normally recommend is that as far as possible, try and eat from the earth, not from a packet. So packaged and processed foods are always full of chemicals. And right at the start, at the time of organogenesis, when your embryo is just growing into a baby, anything you consume can have an effect. As far as possible, if you avoid processed food that contain preservatives, better it will be for you.
okay, all right. So the next question is, I have PCOD and my weight is 90 kgs. So should I try to lose weight first, as I have heard that it increases the chances of pregnancy?
Yeah, that's a very good question. And in fact, it does increase the chances of pregnancy. But there are a lot of factors to be taken into consideration here. What is your height, for example? So, what matters more is the BMI. If you're a very tall girl and your weight is 90 kg, you would only need to lose a little bit of weight. But if you are of an average or of a low height, of a small height, then 90 kgs is a lot of weight for you. So, with PCOS, the management always starts with lifestyle changes first. Lifestyle changes include monitoring your diet, reducing your calorie and your carbohydrate intake, having more of proteins than of carbohydrates, and making sure you have a regular exercise regime in place, even if it is just going for a walk for 4 or 5 times a week. Even a reduction of 5 to 10% of body weight can correct your hormonal disorder, restore spontaneous ovulation, increase your chances of getting pregnant, and not just that, even during pregnancy, somebody who was overweight to start with would have a larger chance of complications, and losing weight before you conceive will keep you healthier during pregnancy as well. Now, that being said, if your weight is 90 kg and say you've already crossed 35 or 36 and you're running out of your ovarian reserve, although losing weight is still ideal for you, but we also know that losing weight is easier said than done. If you let a year or a couple of years go by with your attempts of weight loss, we don't want it to be that you only focused on that and you ran out of the time where you could have conceived naturally or with IUI, because your ovarian reserve is going to be running out as well. So if you are in the older age group, you must still try and lose weight, but simultaneously you can also get your fertility treatments done.
Okay, so ma'am, I think that was the last question for the session. So thank you so much, ma'am, for such a detailed explanation and truly, releasing all the taboos that people might be having about IVF. And it was a really, really nice and an informative session. Thank you everyone for joining us today for the session number 3 for everything about IVF. Tomorrow, we'll be having another session at the same time from 3:30 to 4:30 p.m., where a fertility specialist, Dr. Akash Surana, will be explaining on male factor infertility. See you all tomorrow on the same time on our FB page. Thanks a lot. Thank you so much, ma'am. And thanks everyone for joining.
Thank you everyone for joining in, and we hope you found the session informative. If you have any questions that pop up, you can always write to us on our FB page and we will get back to you.
Thank you so much.